And again, thank you. My topic was neuro ophthalmic causes, which included paralytic strabismus, gaze palsies, which were very well handled by Dr. Nina. So we will just the spasmus Newton syndrome. So what is that? It is infantile onset, variable conjugacy, and with small frequency, low amplitude oscillations. A triad of abnormal head posture, nystagmus, and head oscillations. It improves by, disappears by 2 to 8 years. You could see the thrust the child gave. But anyway, we have to image, because there could be some underlying neurological disorder also. We may not know which patient will be self-limiting the disorder at 2 to 8 years. So if the MRI is normal, we can reassure the patient. So coming to infantile nystagmus, based on the literature nowadays, according to CMA's classification, everything comes under infantile nystagmus, motor as well as sensory. The predominant cause is albinism. Next comes LCA and non-LCA dystrophies, motor, everything. So the conservative management we want to try for nystagmus, there are medications. The brinzolamide is the one I have tried in many patients, but most of them were not compliant. That is different. But few who were compliant were happy. But most often we would not appreciate decrease in frequency of nystagmus, but child or parent would say there is some improvement. The aim of treatment in nystagmus, we all know, it is to shift the null zone. That is to shift the abnormal head posture to the normal head posture. That's all we can do. We cannot do anything more than that. So, and the second aim is to broaden the null zone so that the visual acuity, expanded nystagmus acuity function will be increased by reducing the signal gain of the ocular motor system. This is done by tenotomy and reattachment procedure. And when we try to address the abnormal head posture, we have to address the null zone. The null zone is nothing but where the nystagmus intensity is less, where the fovea gets more time, that foveation time is maximum. So the most common AHP is phase turn in nystagmus, but single AHP usually involves multiple combination, but though one component usually predominates. So how to assess the null zone? It is more like how to assess the abnormal head posture, the same. So allow the child to be in a comfortable environment and allow the child and observe for the AHP or null zone, whatever, without even patient's consciousness, so that you make the child be involved in some activity and you can find out. Then you can also check with accommodation target, because accommodation target can bring out convergence and dampening of nystagmus. That should be also should be found out. And binocular visual acuity 9 cases would help you to confirm, to verify whether the AHP what we have located is correct. Because suppose if we take left gaze, null zone is there, the patient's visual acuity would be more in the left gaze. So 9 cases binocular visual acuity would help in that terms. If we like to try prisms to simulate Kestenbaum surgery, we have to provide yoked prism. Yoked prism is like providing for base down, this for chin up, we are giving base up prisms, either 20 prism, for 15 degree it needs 30 prism diopter. So we have to go for frontal prism. That may not be suitable in a nystagmus patient, because again the vision will be degraded. So it is for just measuring and confirming the AHP. But considering that, we need not differ prism assessment, prism trial in all patients, because see this almost near to 90 degrees, some 70-80 degree chin up posture. This child, to our surprise, he responded very well to, because mother was not at all willing for any intervention. So we thought with prism somehow we will reduce a bit, but to our surprise, with just 8 prism, glass prism, he was reading the above 3 lines. So we prescribed him prisms and he was comfortable. So it is always better to have a prism trial also before we go in for surgery. The surgery indication would be to broaden the null zone, to improve the cosmesis by reducing the abnormal head posture, and also to prevent neck problem. Timing of surgery better to defer until 3 or 4 years because there could be some change in amplitude, directionality and location of null zone. And more than surgery, surgery is technically not at all different or difficult because same resect procedure. The planning and determining the dosage is difficult part in nystagmus surgeries. Importantly, we have to rule out these culprits like all the alternating nystagmus because we operate for right face turn, then post-op visit, if they come with left face turn, it is not at all would be good for both patient and surgeon. So how to rule out these alternating nystagmus? We have to spend time. We have to look for alternation because it may take 2-3 minutes to periodically change. In case of periodic alternating nystagmus, there is aperiodic to add to confusion. Asymmetric duration is there. So everything should be taken into account. And multiple visits documentation is also important so that we can be of sure, okay, this is not alternating, this is stable, then only we have to decide for surgery. Occasionally more than one null position could be there. And that null position can be different for distant and near also. That in a rare occasion, report by Stephen Kraft, where he had noted right face turn for near target and left face turn for distant target. So what he has done in this child is, there was dampening on convergence as well. So he has done bimedial recession, artificial divergence surgery, and partly the face turn was corrected. So what is artificial divergence? It is providing, inducing artificially divergence by providing base out prism in each eye like 6 to 7 prism diopter, and also by adding minus lens so that we can induce this much convergence so that the eye will be in divergence and it still get that convergence effect. Surgery, equivalent surgery is bimedial recession. It is effective in fusing patients. So the recession would be of somewhere 5 to 7 millimeter at least. So otherwise the usual nystagmus surgery is to shift the null zone from the whatever 35 PD to the right. If it is there, we have to shift the eyes 35 PD to the left. So these are all the age-old procedures. Anderson procedure is nothing but recession procedures, recession alone. Kestenbaum is recession and resection. What he recommended is 5 millimeter, resect all the muscles. But then Parks, what he recommends is it would not be suitable. So he came with arbitrary numbers 5, 6, 7, 8, and this 5, 6 is for medial rectus number. And this, if you see, one eye you will be doing 6 and 7, and so 6 plus 7 is 13, and 5 and plus 8 is 13. So 13 equal number in different dosage you will be doing. So this is one Anderson procedure we did for 10-degree face turn. So it was 5 millimeter and 8 millimeter recession. Here this eye undergoes exotropia surgery, LR recession, and this eye undergo MR recession. So reasonably okay, the face turn, and but only for 10 degree it is okay. For more than that, everybody thought the Parks recommendation is not sufficient, so the augmentation come into role, where 20% for 20 degree like that, 21 to 40 degree to 40% augmentation, and 60% for more than 40 degree augmentation. This is from Burton and Kushner. Thanks Dr. Neena for sharing this. Here she had operated for 30 degree face turn. She had done, gone with right stable where 30% augmentation of classic Park values. So 6.5, 8, 9 and 10 was done in both eyes and the face turn was corrected. So usually we prefer to keep two muscles at least untouched so that in future the nystagmus, that is the problem. Future the patient comes.
Excuse me, Dr. Fathima, you may have to wind up now. We have one more talk.
Yeah. Just I'll rush through on just 1 minute. Augmented Anderson is to avoid resection. We will augment the Anderson. So just here is a case where we did 12 millimeter LR recession and 9 millimeter MR recession. This is augmentation. Then augmentation of further augmentation is by plication augmentation, published by Dr. Muralidhar, where instead of resection, plication he had recommended because plication is a reversible procedure. That's what the advantage he claims. And this important point I would tell, if there is coexisting heterotropia, we have to do AHP surgery in the fixing eye and heterotropia surgery in the non-fixing eye. And again, this fusion maldevelopment nystagmus, sometimes what will happen if we correct the strabismus alone, the nystagmus would come down because we are giving binocular vision. So this is a case from Dr. Nina where here this one alone is addressed and the AHP got corrected. So that is also one way of treating. This chin up and down, everything we know. Either based upon up or down, we have to go for inferior rectus. For chin down, instead of inferior rectus resection, we can go for inferior oblique anterior transposition. Similarly, for head tilt, we have to weaken the intorters or weaken the extorters. Thank you. Thank you for listening.